Sensationnel.
Welcome back. In the first part, you learned how to image patients in critical situations. Now we'll show you some causes for critical situations.
According to the UK Resuscitation Council guidelines, the reversible causes of cardiac arrest are the 4H and the 4Ts. Reversible causes are hypoxia, hypovolemia, hyperkalemia, and hypothermia. These are the 4Hs. And the 4Ts are thrombosis, tamponade, toxin, and tension pneumothorax. With ultrasounds, we can assess the issue marked in red: hypovolemia, thrombosis, coronary or pulmonary, tamponade, cardiac. And if we also use ultrasounds of the lungs, we would even see a tension pneumothorax.
Yes, and we will touch on all of these causes because it's not only important to diagnose them in the worst of all cases, namely resuscitation, but also in critically ill patients in general. But let's start with hypovolemia.
Focused cardiac ultrasound in hypotensive patients looks to chamber status, small left ventricular end diastolic and end systolic area, volume status, small collapsible inferior vena cava, and to the kissing papillary muscle sign, that is a left ventricular cavity obliteration. Always check if there is bleeding and don't confuse hypovolemia with hypodynamic situations that could appear like hypovolemia, for example, during sepsis. On the right side, we can see the collapse of the inferior vena cava, that is a typical sign of hypovolemia. Easy to separate the two, but we will hear more on this in the chapter on volume status.
Yes, and if we look at this example here, here are some additional findings that you will find. First of all, again, we have a very small left ventricle. But if you look at the color Doppler, you see that there is flow acceleration in the left ventricle as well, which corresponds more or less with the cavity obliteration. One can see this too here in the two-chamber view. Again, the flow acceleration. Note that the patient also has a very high heart rate, something you frequently find in hypovolemic and hypotensive patients. And if you look at the continuous wave Doppler signal here, you will see those flow acceleration spectrums right here, where we have a very late systolic peak. This is kind of the squeeze of the ventricle where we have a very late gradient. Now, these gradients are not hemodynamically significant, but it helps you to diagnose situations of hypovolemia and very small ventricles. In some patients, we'll even experience what we call a SAM, a systolic anterior motion. You'll hear about that later in one of the future chapters. But at this point, just remember, because the ventricle is so small and the velocity is so high, we have a kind of a pull of the anterior septum towards the septum, which kind of occludes the LVOT and thereby causes obstruction. We also call it dynamic obstruction. Look at the four-chamber view here on the left and also at the color Doppler study on the right, where we have flow acceleration right at the point where the mitral valve is actually touching the septum. There's also some degree of mitral regurgitation. So this is a phenomenon you will see very frequently in patients who have hypertrophy to start out with and who then also have hypovolemia. And it is also a situation that, as you well know, in cardiovascular surgery is something you have to be aware of.
Yeah, of course. It can make things even worse because it causes flow obstruction and hypotension.
And Bruno, there is one more sign.
Yeah, Thomas. We have the kissing papillary muscle sign. And as we can see in this video, you will see the obliteration of the left ventricle and the two papillary muscles will touch themselves.
So echocardiography is really valuable to diagnose hypovolemia and to look at volume status. And we'll actually devote an entire chapter to this topic as well. It'll be chapter 13. But now let's talk about cardiogenic shock and see how echocardiography can help us here.
The presence of a cardiogenic shock should be very well investigated using a focus. It allows us to distinguish right ventricular from left ventricular failure or biventricular failure. Look for global function first, but don't forget wall motion abnormalities and movement of atrioventricular valves. The investigation by focus of ventricular function during cardiogenic shock will facilitate to understand which kind of support the patient needs. That's to say, inotropic drugs or mechanical support. In this example of a typical myocardial infarction, if you look closely, you will see not only a global impairment and dilatation of the left ventricle, but a complete asynetic apical segment as well.
So what about this patient? He had a blood pressure of 70/40 and very poor left ventricle function. Does he also have hypovolemia?
No, Thomas. This patient has a very large left ventricle. It is hypocontractile, and the valves are not moving a lot. This is a patient with a low cardiac output, for sure.
Yeah, this is end-stage heart failure. As a matter of fact, this patient died only 3 hours after we performed this echocardiogram. So a very tragic case, of course, but it just shows that if you have a patient like this, you could easily separate it from hypovolemia versus a patient who has, I would say, a very poor left ventricular function, low cardiac output.
And here, a very similar picture, only that is a patient that has a large anterior infarct. See also, he has a pleural effusion, you can see here, very nice. And it's a completely different picture than hypovolemia.
Yeah, but not always, because here's an example of a patient who has very acute mitral regurgitation. This was a patient that underwent mitral valve valvulopathy and where one of the leaflets ruptured, and he was also in cardiogenic shock. And in this case, you have a very hyperdynamic left ventricle, but obviously the ventricle is pumping everything backwards into the left atrium opposed to the aorta. So another cause that we can actually find with echo. So let's summarize. Cardiogenic shock is usually associated with poor left ventricular function, except in the situations of acute volume overload, as the example we saw previously with acute mitral regurgitation. Let us now turn to another very important application of echo, tamponade. Tamponade is a real game changer. But how do we diagnose it?
Yeah, Thomas. In case of a suspect of pericardial effusion or tamponade, you should look for the pericardial effusion and especially how big it is. Typical signs are a chamber collapse, right atrium, left atrium collapse in systole, right and left ventricle collapse in diastole, and non-collapsible inferior vena cava and hepatic vein. And the last sign is the swinging heart by large effusions.
Yes, but keep in mind that the word tamponade is actually reserved for those very acute situations where you have rapid fluid accumulation, which causes acute hemodynamic compromise of the heart. Sometimes it can happen much more slowly, or for example, a fluid can accumulate over weeks or days, and there you would not have this very acute situation. Those would be more subtle forms of tamponade. But here is such an acute form of tamponade. If you look closely, you see that there is a compression of the right ventricle right here, and there's a little bit of fluid accumulating here by the right ventricle. So not a lot of fluid. This is enough to cause tamponade. It was in the patient that was actually intervened with a coronary rupture of the circumflex artery causing acute tamponade. Now, if you look at the echo here on the right, you see that now the left ventricle is much larger, the right ventricle is expanded, and everything went well after the fluid was drained. And here again, another example. A very small pericardial effusion in the region of the right ventricle, which causes compression and tamponade. Look at the heart rate, it's very high. And here you have the result after the fluid was drained. So remember, small pericardial effusions can cause tamponade. It's not a matter of how much fluid is in the pericardial sac. And here's an example where you have a lot of fluid suddenly expanding into the pericardial sac in a patient who had rupture of the aortic sinus. You see that we still see the free-flowing blood right here, and this definitely causes a tamponade. You don't even have to check for the signs of tamponade. If you see this, you better run.
This is another case where we see the pericardial effusion is limited to the apex of the right ventricle. This is a patient after heart transplantation that received a biopsy. And this is the complication, a typical complication of the biopsy.
And here, a patient who has a very large pericardial effusion, which is hemodynamically significant. You see that there is compression of the right ventricle, that the right atrial wall is kind of collapsing inwards, and probably a pericardial effusion that was, I would say, developing over a certain time, at least days, I would say. Nevertheless, you see many of the signs that are typical for tamponade, such as even, I would say, compression of the left ventricle. And this is another example of an even larger pericardial effusion. This is a classic example of a swinging heart. You see that the left ventricle is swinging back and forth in the pericardial sac, and I would think how much fluid is in there?
Probably 500, 600
milliliters at least, yeah.
And there is another image of the typical swinging heart, and we see the four-chamber view, and we see really a lot of effusion in pericardium. This is probably 1 liter, something like this.
This example is probably one of the most dramatic cases I've seen. It's not from our collection, but actually from a colleague from India who sent me this image from Dr. Aniruddha Dey, and he was able to actually document the moment of rupture of a free lateral wall in a 55-year-old patient who had a circumflex infarct with myocardial rupture. What you actually see here is, you see that there is flow out of the left ventricle into the pericardial sac, something you will very rarely see, only in the moment that that happens, because that usually goes so quickly that the patient deteriorates and die. That is actually what happened in this patient as well. I think there is another image where you see that very nicely. Here you see the blood that is in the pericardial sac, and you see the tamponade that is occurring with this rupture, a very dramatic case.
The next emergency situation is the pulmonary embolism. But how can we diagnose it? The possibility to detect directly a clot is not very big. And in the most of cases, you need a transesophageal echocardiography. There are some indirect signs like dilated right ventricle, impaired right ventricle free wall function with or without intact apical function. And naturally, the D-shaped sign, that is a systolic septal flattening.
Yes, Bruno, we talked about this in the chapter number 14, where we will deal with right heart disease. But let me see the features that you see in transesophageal echocardiography.
Here it's very nice to appreciate the clot in the right pulmonary artery, but I have to say, during every year I will call from other intensive care unit at least 10 or 15 times to diagnose a pulmonary embolism. But I have never found such a nice image like this.
I must, of course, admit that this is also a patient that did not have acute pulmonary embolism, but a patient who had chronic thromboembolic pulmonary embolism. And in these patients, you would see it more frequently. I agree with Bruno that it's not commonly found, but if you do find it, I think it does change a lot, doesn't it?
Yeah. Here is a classic example of pulmonary embolism with transthoracic echocardiography. We see a large right ventricle, poor right ventricle function, but watch out, right ventricle infarct can look very similar to this condition.
Yeah, you have to distinguish the two. But if you look at this image and you know that he has pulmonary embolism, is this an indication for thrombolytics?
Yeah, probably, yeah.
Yeah, so if he has hemodynamic compromise, we know that there is probably a very large pulmonary embolism, and these patients definitely benefit from thrombolytics.
And this one is an example of a patient with the right ventricular infarct. And you can see that they look very similar.
Yeah, both have a large right ventricle, both have a poor right ventricular function. If you look at the pulmonary pressure of these patients, very frequently you will find lower pressures in right ventricular infarct because the right ventricle cannot generate such high pressures. And you would find probably higher pressures in pulmonary embolism. But if no TR is present, it's literally not possible to distinguish the two.
Yeah.
But Bruno, does echocardiography always rule out a pulmonary embolism?
No, especially not in smaller pulmonary embolism. Sometimes one doesn't see anything. And here is such an example.
Yeah, this patient had a documented pulmonary embolism, more in the periphery of the vessels, and he has tachycardia, but you don't see anything else. You don't see a dilated right ventricle, and to make the diagnosis from the echo is literally, in this case, impossible. But the information is very important that we still get from this echo. We know that the patient does not have any hemodynamic sequels of the pulmonary embolism, and that also drives our decision as what to do. Yeah. And next question, what do you actually see in the transesophageal echo if you have pulmonary embolism?
Thomas, we can see in this image a D-shaped right ventricle, and with the transesophageal probe, the right ventricle pushed the septum toward the left ventricle, reducing for sure the stroke volume of the left ventricle.
Yes, we see that with transthoracic echo as well, and you will hear more about that in the specific chapter we have on right heart disease. So let us conclude.
Use echo to check for mechanical activity, especially in PEA, and look for the cause. In hypovolemia, look for small left ventricle, hyperdynamic ventricle, and collapsed inferior vena cava. In cardiogenic shock, look for poor left ventricular function, wall motion abnormalities, and a dilated left ventricle. In tamponade, you will see some fluids or an hematoma, and you look for compression of the chambers. And in the pulmonary embolism, the right ventricle dilatation, the poor right ventricle function, and the D-shape are typical signs.
Yes, Bruno, and this concludes our chapter on echo and advanced life support, but there are associated chapters where you will find in-depth information, for example, in complications of myocardial infarction, on the chapter on right heart disease, on fluid management, and on pericardial disease.